I'm Peter Block here in Chicago at the AHA annual meeting for On the Scene, and with me is Laura Morey from the Brigham and Women's in Boston, my old stamping grounds. Laura is part of the dual antiplatelet therapy study. Once again, we have to talk about dual antiplatelet therapy, but in fact, Laura, what I want to talk to you about is not so much the study itself, but the implications of this, because you were part of the much longer dual antiplatelet therapy study, 30 months. So tell me a little bit, first quickly, what and how long did you follow these patients?
So we followed patients for almost 3 years after coronary stents, and they were randomized after a year to either get clopidogrel or prasugrel plus aspirin versus aspirin alone.
Okay, so they had some antiplatelet therapy, but the clopidogrel group went out to 30 months, as did the aspirin group. You followed them out. Tell me what, I guess, the short version of the outcomes. In your brain, what is the important finding here?
Right, so the important finding was that both stent thrombosis and myocardial infarction were reduced. Stent thrombosis by 71%, and myocardial infarctions were cut in half by continued thienopyridine, whether it was with clopidogrel or prasugrel.
Okay, what are the absolute numbers there? I mean, it's always nice to know 50%, 1 to 2 is 100% difference. So what are the actual numbers?
Yeah, the number needed to treat for stent thrombosis was 100, and for myocardial infarction was just 50.
Okay, so that really is an important difference, and we're really seeing differences here. Okay, so let's move on. Interesting trial, positive trial, lots of good things for dual antiplatelet therapy long-term. Should everyone have long-term dual antiplatelet therapy? Question number one.
Well, we saw a 2 percentage point reduction in myocardial infarction over just 18 months among these coronary stent treated patients. So I think the results directly apply to patients who get a coronary stent. It's probably consistent with drug-eluting or bare metal stents. So this is less about what kind of stent, because we saw these reductions regardless of the kind of stent that they received. So I think we're going to be thinking as we see our patients, as long as they've tolerated therapy for the first year, to keep them on it.
Okay, tolerated means I guess we get to be doctors again, don't we, Laura? We get to decide whether a patient has a higher bleeding risk or some other negative reason to stop versus the long-term goodness that comes out of a 30 or 40 month or longer dual antiplatelet therapy. Would you agree?
Yes, well, in the trial we actually kept it fairly simple in that the patients who did not get randomized were those patients who had major bleeding, because we didn't think that they could tolerate antiplatelet therapy, or patients who'd had an MI or other events that made it mandatory that they keep on taking dual antiplatelet therapy. So it's those patients who you might see in the office who are actually doing well without either of those events that you would think about putting on continued therapy.
Well, now you are really deviating here, Laura. You're talking about taking care of patients rather than just dual antiplatelet therapy for a stent. We're talking about the general patient. We're talking dual antiplatelet therapy sort of in the same class as statins. Is that fair?
I think that is fair. We saw such a huge magnitude of risk reduction over such a short period of time. And then as patients came off of drug, we had the opportunity to watch them as well, and they had an uptick in the numbers of heart attacks over the time that they were coming off. So I think it's very reasonable to think about these as another class of medications for secondary prevention.
Okay, well, I think the teaching point here is quite clear. You've said it beautifully, Laura. Sounds to me like we're starting to think about dual antiplatelet therapy very much like preventive cardiology, very much like statins for patients with coronary disease and high-risk profiles even. Mm-hmm. Thank you for being here.
You're welcome. My pleasure.